My name is Hirotoshi Iihara, a pharmacist at Gifu University Hospital. Today, I'll share an important update on CINV for 2025. I briefly walk you through these 5 key points. Before looking at the new evidence, I'd like to pause for a moment. Cancer therapy is not only about controlling the tumor. Supportive care is essential to maintain treatment continuity and patient care. Let me start by explaining why CINV management matters. This slide summarizes a study evaluating the impact of treatment-related side effects on the health of ovarian cancer patients receiving cisplatin. As highlighted in red, CINV was identified as one of the most undesirable health-related concerns among patients, with the exception of very mild symptoms. These findings clearly demonstrate the substantial negative impact of CINV on patient care and underscore its relevance for treatment adherence and continuity. This figure shows the result of a meta-analysis of phase 2 and 3 trials in patients with recurrent ovarian cancer. As shown here, patients who experience severe CINV, defined as grade 3 or 4 and indicated by the green line, had significantly shorter survival compared with these with mild or no CINV, shown by the blue and red lines. This data suggests that severe CINV is not only a cure issue, but may also be associated with survival outcomes, further emphasizing the importance of appropriate CINV management. Given this impact, the challenge is how to deliver appropriate antiemetic care tailored to individual patient risk. The next step is optimization in clinical practice. The JTOP-B trial showed that effective CINV control does not necessarily require higher dose of Olanzapine. A 5 mg dose provided robust efficacy with better tolerability. These findings support dose tailoring as an important step toward personalized antiemetic care. Importantly, across all major international guidelines, 10 mg remained the standard and most extensively studied dose of Olanzapine. Lower doses such as 5 mg are mentioned only as an option, mainly when tolerability, particularly sedation, is an issue. Against this background, the JTOP-B trial provides high-quality evidence to support dose optimization without compromising efficacy. This slide summarizes the design of the JTOP-B trial. This was a multi-center, double-blind, randomized phase 3 trial in 500 patients receiving AC chemotherapy. Patients were randomized to Olanzapine 5 mg or placebo, on top of standard antiemetic therapy. The primary endpoint was overall phase complete response, defined as no emesis and no rescue medication. An important feature of this study was the dosing schedule of Olanzapine. Olanzapine was administered within 5 hours after chemotherapy on day 1, and after dinner on day 2 to 4, a schedule designed to minimize daytime sedation while maintaining antiemetic efficacy. First, I would like to share the primary endpoint, overall phase complete response. Overall phase complete response was achieved in 58.1% patients receiving Olanzapine, compared with 35.5% in the placebo group. That represents an absolute difference of 22.7%, which was statistically significant with a p-value of less than 0.0001. These results demonstrate that even a 5 mg dose of Olanzapine initiated after AC chemotherapy provides effective CINV control across the overall risk period. Next, I will briefly address safety, focusing on daytime somnolence. Overall rates of somnolence were similar between the two groups. Severe daytime somnolence was observed somewhat more frequently with olanzapine, but this effect was mainly limited to the early treatment period. Importantly, daytime somnolence tended to improve over time in both groups, indicating that this adverse effect was transient and manageable. Finally, I will briefly address decreased concentration, which is closely related to somnolence. There were no meaningful difference between the olanzapine and placebo group, either for overall or severe decreased concentration. These findings indicate that adding olanzapine at a dose of 5 mg did not result in a clinically meaningful impact on daily functioning. Alongside the established evidence for the 10 mg dose, high-quality evidence supporting the 5 mg dose has now accumulated, including large randomized trials such as JFOS and JTOP-B. Taken together, in patients receiving AC chemotherapy, Olanzapine 5 mg represents a practical, evidence-based dose-tailoring option that balances antiemetic efficacy and tolerability. Now, let's turn to CINV in the ADC era. Antibody conjugate or ADCs have become an important class of anti-cancer therapies. Despite their targeted design, ADCs, particularly T-DXd, are frequently associated with nausea and vomiting, with nausea occurring in up to 60 to 80% of patients, and vomiting in 25 to 45%. A key feature of ADC-related CINV is its delayed and long-delayed time course, with nausea and vomiting occurring several days after treatment and often persisting. In the ADC era, CINV has emerged as a long-delayed problem, underscoring the need for time-adapted antiemetic strategies. There is inconsistency in how guidelines classifies the emetogenic risk of TDXD. NCCN classifies TDXD as highly emetogenic chemotherapy, while Mask ESMO places it at high end of moderately emetogenic chemotherapy, and ASCO classifies it as MEC. As a result, antiemetic recommendations also differ, with Mask ESMO recommending 3 agents, whereas ASCO recommends 2. Given the substantial burden of nausea and vomiting observed with TDXD and these different guideline recommendations, we conducted a clinical trial to address this gap. Before showing the more recent ADC trial, I would like to briefly introduce an earlier exploratory study that first addressed this clinical question. Since the rate of nausea and vomiting with TDXD and antiemetic prophylaxis were unclear, we conducted a multicenter open-label randomized exploratory phase 2 trial. Patient was stratified by age and prior experience of CINV. In the GD arm, patient received glycetron and dexamethasone. In the GDA arm, they received glycetron, dexamethasone, and apreptant. The primary endpoint was complete response from 0 to 120 hours. The complete response rate was 36.8% in the GD arm and 70.0% in the GDA arm. This difference was statistically significant with an odds ratio of 0.1334 and a p-value of 0.0190. These results suggest that the triplet regimen provides better antiemetic control than the doublet regimen. This figure shows time to treatment failure in the GD and GDA arm. Time to treatment failure was significantly longer in the GDA arm. Most treatment failure occurred within the first 3 days, but importantly, Failure continued beyond this period. Even with aprocitentan in the triplet regimen, delayed treatment failure was still observed. This indicates that TTF in this setting primarily reflects delayed and long-delayed antiemetic failure rather than acute phase events. With this background and the earlier study in mind, let's now move on to the 2025 evidence from the ERICA trial. In this trial, the added effect of olanzapine at a dose of 5 mg was evaluated on top of acetylone and dexamethasone. Patients receiving T-DXd were randomized to receive either olanzapine or placebo, in addition to standard antiemetic prophylaxis. Although patients were observed for 21 days, the primary endpoint focused on complete response during the delayed phase, 24 to 120 hours. Please focus on the delayed phase complete response rate highlighted in red. In the ERICA trial, adding olanzapine improved the complete response rate from 56.1% to 70.0%, demonstrating a clear added benefit during the delayed phase. Now turning to the area highlighted in purple, although the primary endpoint focused on the delayed phase, patients were followed for a total of 21 days, and complete response rate continued to decline over time. This finding suggests that CINV associated with T-DXd can persist beyond the conventional delayed phase and extended into a later phase. This graph shows episode of vomiting and the use of rescue medication in the olanzapine group. As highlighted in purple, vomiting was still observed after day 6 in 12.5% of patients. Among patients who did not achieve complete response, the rate was 17.5%, indicating that vomiting persisted into the later phase. This finding is noteworthy as vomiting is generally expected to be well controlled by NK1 receptor antagonists. These findings indicate that delayed and long-delayed nausea and vomiting remain a key challenge with T-DXd. One potential approach to address this issue is the use of a long-acting NK1 receptor antagonist, such as netipitant. This graph shows model predicted NK1 receptor occupancy in the striatum over time. Netipitant demonstrates sustained receptor occupancy over an extended period, maintaining substantial NK1 blockade even beyond the first week. This prolonged pharmacologic effect suggests that netipitant may provide more durable control of nausea and vomiting in the long-delayed phase. Now let's shift the focus to personalized antiemetic care. First, I'd like to briefly highlight earlier work in patients receiving highly emetogenic chemotherapy, where this concept was initially established. This figure shows that patients receiving highly emetogenic chemotherapy are not homogeneous in their risk of CINV. A simple risk score identifies a subgroup of patients. A particularly high risk provided a clear rationale for risk-adapted antiemetic intensification. This concept later evolved into the MyRisk approach. From here, I'd like to introduce the MyRisk trial, published in 2025. This study focused on patients receiving moderately emetogenic chemotherapy and was based on a different concept from conventional antiemetic prophylaxis. Rather than relying solely on the emetogenicity of the regimen, the MyRisk trial incorporated individual patient risk factors to personalize antiemetic care. In other words, the goal was to identify which patients truly need triplet antiemetic prophylaxis in advance. In this trial, patients assessed as high risk were selected, and the value of NEPA-based triplet therapy was evaluated specifically in this population. The MyRisk trial therefore represents a new risk-adapted approach toward personalized antiemetic care. This slide shows the CINV risk score used in the MyRisk trial. A baseline score of 10 points was assigned with point added or subtracted based on 7 predictive factors, including age, psychological factors, prior history of morning sickness, and treatment-related variables. Factors such as younger age, anticipation of nausea, and a history of morning sickness increased the score, whereas prior chemotherapy exposure reduced it. Patients with a total score of 13 or higher were classified as high risk, and in this population, the efficacy of NEPA-based triplet prophylaxis was evaluated. Importantly, antiemetic prophylaxis in MyRisk was selected based on individual patient risk rather than regimen emetogenicity alone. This slide shows the design of the MyRisk trial. Using a validated risk score, 410 patients receiving moderately emetogenic chemotherapy who were identified as high risk were enrolled. Patients received either a NEPA-based triplet regimen or standard doublet therapy with cetron plus dexamethasone. Treatment was given across 3 cycles, and the primary endpoint was overall complete response across all cycles. This slide shows the result of the MyRisk trial. The figure represents complete response rate over the overall phase integrated across 3 chemotherapy cycles. The complete response rate was 81% in the NEPA plus dexamethasone group, compared with 71.8% in the standard cetron plus dexamethasone group, demonstrating a statistically significant benefit of triplet prophylaxis. In other words, even in moderately emetogenic chemotherapy, patients identified as high risk achieved more reliable CINV control with triplet antiemetic therapy. Importantly, this trial provides the first prospective evidence supporting a risk-based approach to identifying which patients truly need triplet antiemetic prophylaxis. In 2025, the focus shifted from asking whether antiemetic strategies work to understanding how to optimize care for individual patients. We optimized Olanzapine dosing and recognized that the CINV risk window extends in the ADC era, particularly in patients treated with TDXD, where standard doublet prophylaxis may be insufficient for many patients. At the same time, the MyRisk trial showed that intensification should not be applied uniformly, but selectively based on patient risk. Together, these insights define a move toward risk-adapted, patient-based antiemetic decision-making beyond regimen emetogenicity alone. Look ahead to 2026, the focus will be on implementation, translating evidence into guidelines, education, and simple tools supported by multidisciplinary collaboration to deliver risk-adapted, patient-based antiemetic care. Before closing, I would like to acknowledge and thank the past chairs, steering committee members, and colleagues of the Mask Antiemetic Study Group, whose leadership and dedication have shaped the field of antiemetic care. I would also like to express my sincere gratitude to the Mask headquarters team for their essential support, which enabled this global collaboration to move forward. Thank you very much for your attention.